Hi, very good morning, everyone. I would say very cold morning, everyone. The weather is changing everywhere. It's a global warming. We are seeing unexpected weather. So, with this weather note, we are discussing a very important topic about diabetes. I think this is need of an hour. A lot of people would be asking answers, having doubts. Is diabetes reversible? So, we have a very eminent personality, Dr. KP Chandra. He's a director for Department of Internal Medicine and Diabetic Care, Health City Vistar Hospital, Gomti Nagar, Lucknow. He's a fellow member of ICP, ISH, UPDA, EASD Netherlands, ISMN, IACM. He's also a fellow in Indian Society of Chronomedicine Research Trust of Diabetic India. He was a senior scientist with Department of Drug Discovery, Clinic Research of Translation Medicine, Torrent Research Center in Gandhinagar. He has more than 25 publications in his name. Sir, over to you.
Thank you very much, Dr. Saurav. Thank you, ICGP, and all people who have joined together from different part of the globe. And we are going to, of course, discuss today about reversal of diabetes. I mean, this topic is a lot of interest because everywhere on the social media, you just put this name diabetes and you will get reversal of diabetes, and this concept is being sold by each one of us. I mean, most of the people around left and right, and people keep on doing. So we really need to understand what is this reversal of diabetes. What are the patient populations where reversal of diabetes can be attempted? What is the basic concept? What is the pathophysiology of diabetes because of which we have started talking about reversal of diabetes? And dissemination of the correct information about reversal of diabetes is very important. As we have already been discussing, the prevalence of diabetes is increasing gradually. Around about 6 to 7% of the population worldwide do have diabetes. And recently in India, we did have a INDIAB study which did show that prevalence of diabetes was around 7 to 8% in India. And more importantly, around 15% of the population were pre-diabetes. So we are sitting on the time bomb which can explode, and all these people, they say that 100 million people are already having diabetes in India, and another 150 million people are on the verge of getting diabetes. So the concept of reversal of diabetes is very, very important at this point of time. And the population who are pre-diabetes, who are just going to convert into diabetes, for that population reversal of diabetes is really, really very important if we really wish to decrease the global burden of diabetes on our population. So the first question that I'm going to try to address is diabetes really reversible? So let me tell you what we have been thinking, or we have been talking about in past century, that diabetes is inevitably a lifelong disease. It is usually irreversible, and that is because of the progressive beta cell damage. However, after the results that we started having from bariatric surgery, in which there was a restoration of normal glucose metabolism, in most of the patients of type 2 diabetes, this concept of reversal of diabetes started coming in. And what were the mechanisms which led to this effect? That was, we tried to understand that how this reversal of diabetes has been set in people who have bariatric surgery, and what it could be seen that there were some changes in gut hormone. So we will be talking a lot about GLP-1 and GIP-1s, and then profound decrease in calorie intake. We all know that by bariatric surgery, what we are doing is decreasing the caloric intake. Either we are bypassing it, or we are decreasing the volume of the stomach. So amount of calories that is being absorbed is drastically decreased. So these were the two important phenomena which were thought thought to be causing reversal of diabetes after bariatric surgery. So a lot of research has occurred in past 2 decades about this concept of reversal of diabetes and which has come in. So before I go and talk about reversal of diabetes, let us understand the difference between a remission of diabetes and reversal of diabetes. When you talk about reversal, it means that you are restoring the good health. You are removing the pathophysiology. And when you talk about remission, it means you are leading to, or there is abatement or disappearance of signs and symptoms of disease. So these are two different things. When the disease process itself has reversed, now you have got no pathophysiology associated with diabetes, you will call it reversal. And in remission, sign and symptoms have went out, although pathophysiology may still remain. So these are two differences that we need to understand. And I would say that for chronic illnesses like diabetes, it will be more accurate to say remission than reversal. Okay, the one thing that I wanted to say clear, type 1 diabetes is not reversible. So when we talk about reversal of diabetes, we are exclusively talking about reversal of diabetes in type 2 diabetes. So there should not be any confusion that type 1 diabetes is reversal, because on social media you can get a lot of wrong information that type 1 diabetes is also reversible. So before we go ahead, let me uh, you know make it clear that whatever I'm talking to is related to type 2 diabetes, and type 1 diabetes is not reversible. So let us think about remission of diabetes. As I told you, reversal means complete pathophysiological reversal. That is something which really needs a lot of efforts. I don't know how many people would be going in reversal. So in place of reversal, let us talk about remission of diabetes, which seems to be a practical approach to people living with diabetes. So the first thing is partial remission. Partial remission means having blood glucose that does not meet classification of type 2 diabetes for at least 1 year while not taking any medication to lower blood glucose. So when you talk about diagnosing type 2 diabetes, fasting blood sugar 126 or more than that, postprandial 2 hour postprandial blood sugar more than 200, or HbA1c more than 6.5. So if a person's blood sugar level is fasting blood sugar level is less than 126, postprandial blood sugar is less than 200, HbA1c is less than 6.5, at least for 1 year, without any medication to lower blood glucose level, we call it partial remission. Now, complete remission means the blood sugar level has come down to the normal level. So, fasting blood sugar less than 100, postprandial blood sugar less than 140, and HbA1c less than 5.7. So, complete remission means blood glucose level in normal range for at least 1 year while not taking any medication to lower blood glucose level. And what we call prolonged remission, a return to normal glucose values at least for 5 years. That is called prolonged remission. And when you have prolonged remission, you may say that yes, probably there has been a reversal of the disease process, and that is what you can claim about. So, what we need to understand when we are talking about remission or reversal, when you talk about reversal, we need to understand what is pathophysiology of type 2 diabetes, how prolonged decline in beta cell function occurs, and how this concept has evolved from 20th century to 21st century, how this concept has changed, and because of which we are talking about reversal of diabetes. So this is typical therapeutic progression over the time in type 2 diabetes. What we have been understanding that there is progressive beta cell dysfunction, and as beta cell dysfunction continues, we keep on optimizing treatment, we keep on intensifying, beginning with lifestyle plus OAD. I mean, this is typical therapeutic, what we see in our clinics. We'll try to understand when I'm talking about remission or reversal of diabetes, I will try to emphasize upon that how the change has to be done in typical therapeutic progression so that reversal can be obtained. So lifestyle OAD, then we add up basal insulin, then up titrate it, and this is how the disease progresses. Now, what we see here, or the message what we learned from UKPDS over the time, that yes, in intensive treatment arm, there was improvement in HbA1c to begin with. So intensive treatment intensive they try to keep HbA1c less than 7%, or there was around 7%. In conventional therapy, there was 7.9%. What we did see that over the time, there was progressive decline in beta cell function, and this glycemic control deteriorated in type 2 diabetes with progressive beta cell, whatever be the intensity of treatment. So this is the pathophysiology. And why this beta cell dysfunction occurs? This is because of a number of factors: chronic hyperglycemia and glucotoxicity. So, continuous exposure of pancreatic beta cell to high level of glucose leads to its destruction. Similarly, hyperglycemia leads to over secretion of insulin to compensate insulin resistance, which also leads to beta cell exhaustion and lipotoxicity. So these things come together, lead to beta cell dysfunction. And glucotoxicity, lipotoxicity, chronic hyperglycemia, hyperinsulinemia, all these things put together lead to beta cell dysfunction. Now, what we have learned out of when we treat patients of type 2 diabetes, how does affect beta cell functions? So this is what we will try to understand. The first thing that we need to understand is impact of lifestyle intervention. So this was a beautiful study, 6-year darkwing study. There was 6 years intervention for lifestyle. I would say that more than 500 patients were with impaired glucose tolerance were included in this study. One group received intensive lifestyle modification, and another group was control. And these patients were followed for 20 years. And new development of diabetes in these two treatment arms were evaluated. And what it was seen over the time, that when intervention was done right at the time of pre-diabetes level, a lifestyle intervention led to 49% lower incidence of type 2 diabetes, even up to 20 years of follow-up. So when you treat diabetes and when you talk about reversal of diabetes, these are the interventions which has to be taken into consideration. This was another study. Once again, I would say that more than 3,000 patients were included. 3 groups: placebo, metformin, and lifestyle intervention. Once again, these patients were in pre-diabetes, and cumulative incidence of type 2 diabetes was studied for more than 4 years. Average duration was 2.8 years. And what it was seen, that there was 58% lifestyle intervention, 58% risk reduction in cumulative incidence of diabetes with lifestyle intervention, and 31% with metformin. So when you talk about these data, the concept that this disease is progressive becomes questionable. There are certain interventions by which this disease process can be halted, that can be stopped. These are the evidence which led us to think about what is the vicious cycle and can we stop this vicious cycle. So what happens when there is metabolic dysfunction and insulin resistance? Our pancreas tries to compensate it. So there is hyperinsulinemia. With hyperinsulinemia, there is increased hunger. With increased hunger, there is increased chronic calorie intake, which ultimately leads to this vicious cycle. So if we tend to stop the disease progression, if we tend to reverse the disease activity, this vicious cycle has to be stopped. You have to cut it somewhere so that reversal can be obtained. And thus, came the famous twin cycle hypothesis given by Roe Taylor. It says that when there is positive calorie intake, there is increased fat in the liver. So the role of fat comes in. Now this increased fat in liver leads to resistance to insulin, suppression of glucose production in liver. That leads to increased basal insulin secretion. Increased fat in liver leads to increased VLDL triglyceride. That leads to increased islet triglyceride, which ultimately leads to decreased insulin response to ingested glucose. That leads to increased postprandial glucose. Thus, plasma glucose is increased. So what it says that the chronic calorie excess leads to accumulation of liver fat with eventual spillover into the pancreas, eventually causing metabolic inhibition of insulin secretion after meal and onset of hyperglycemia. So if you have to reverse it, the fat accumulation in the liver and triglyceride has to be decreased. So what happens? When you reverse this twin cycle, it will effectively improve the beta cell function. So isocaloric balance after substantial weight loss. So there is a weight loss, then liver fats are normal. So there would be normal basal insulin secretion, normal insulin sensitivity, and control of glucose production leading to normal plasma glucose. Similarly, there is decreased fat spilling over to pancreas. Whatever fat spilling is occurring from the liver, it may get deposited in subcutaneous fatty storage capacity. So there is decreased islet triglyceride, which ultimately leads to normal insulin response to ingested glucose, and that ultimately leads to normal postprandial glucose. So this cycle, the fat accumulation seems to be a pathway. If this is intervened, reversal can be possible. Now let us talk about certain other evidence that we do have about diabetes remission and reversal. Why I'm talking about all these things? Because yes, reversal or remission is possible. We do have long-term follow-up studies from different studies, and that's why this concept has come in, and we have to take out messages from these and try to find out which patient group is the best patient group in which we can target for remission or reversal, and what are the best methods to do that. So this direct study, I believe all of you have might have heard about it. This was an open level cluster randomized trial at 49 primary care practices in Scotland and England. Weight management program was done with best practice for the care of the guideline. Inclusion was people aged 20 to 65 years of age and recently diagnosed type 2 diabetes. So type 2 diabetes within 6 years, body mass index of 27 to 45, and none of them were receiving insulin. And the intervention was all anti-diabetic drug, antihypertensive drug was withdrawn, and a total diet replacement in the range of 825 to 853 kilocalories per day was done for 3 to 5 months. And these are the results. Let us see. The proportion of patients achieving more than 15 kg body weight was 24% in intervention group versus 0% in control group. Proportion achieving remission of diabetes as 12 month was 46% in intervention group. So weight loss of 50, and then let us see about the proportion of patient achieving remission in terms of weight loss. So those who didn't have weight loss, there was no remission. Those in whom there was weight loss was less than 5 kg, 5%, the rate of remission was 7%. Where weight loss was in between 5 to 10 kg, remission was 34% seen at the end of 12 months. In whom weight loss was 10 to 15 kg, remission was up to 57%. And the group where remission was more than 15 kg, 86% of the people had remission of diabetes at 12 months. So the message that we get out of this study is weight loss of 56 kg or more in 24% of the participant in intervention group and no participants in control group, and where there was more than 15 kg weight loss, chances of remission was 86%. The second message that we get, diabetes remission occurred in 68, that is 46% of the participants in intervention group. So yes, intervention at right time with diagnosis of diabetes less than 6 years with good weight loss has led to diabetes remission in this case, in this study. So at 12 months, almost half of the participants achieved remission to non-diabetic state and off anti-diabetic drug. Remission of type 2 diabetes is a practical target in primary care, and the concept of remission of diabetes does exist. Now, let us see some other intervention. We saw the impact of lifestyle intervention. Now, impact of GLP analog. GLP analog has got multiple positive impact on the beta cell. We all know type 2 diabetes patients do have compromise in the beta cell. In type 2 diabetes patient, use of GLP-1 receptor agonist leads to improved beta cell function, improved secretory capacity, increased beta cell glucose sensitivity, decreased pro-insulin to insulin ratio, and increased first phase insulin secretion. Now, this is a study comparing the impact of liraglutide plus metformin, liraglutide alone, metformin and glimepiride alone on beta cell function from baseline after 5 years as studied by HOMA-IR. And you can see that with liraglutide and metformin, there was significant improvement in beta cell function. Impact of semaglutide on beta cell function. This was once again studied in terms of HOMA-IR, HOMA-B, and what we could see that semaglutide improves beta cell function in patients with type 2 diabetes. This was from a step 2 trial. Now, the another most common aspect, insulin therapy, how does it impact? So there are evidence of early intensive insulin therapy helping in remission of diabetes. These are the 3 studies that I would like to quote here. To begin with, beta cell function preservation after 3.5 years of intensive therapy. So early intensive insulin therapy for type 2 diabetes remission. Intensive diabetes therapy helps in beta cell preservation is what we will try to understand. So to assess the beta cell function after 3.5 years of intensive therapy, treatment naive newly diagnosed type 2 diabetes patients were included in this study. In one arm, insulin therapy was given, biphasic insulin plus metformin, and in another arm, triple oral therapy was given, metformin, glyburide, and pioglitazone. And target fasting blood sugar was 72 180, target postprandial blood sugar was less than 140. And this is how the impact was seen on different aspects of beta cell function. So C-peptide level in insulin therapy, C-peptides tells about intrinsic insulin secretion. In insulin therapy, you can see there is substantial increase. Glucose AUC was better in insulin therapy. Ratio of C-peptide versus glucose was better in insulin, and patients who were on insulin had better HbA1c control. The message that we want to get out of it, that if you treat diabetes intensively in the beginning itself, it helps in beta cell preservation, it helps in insulin secretion. The message that I want to give is when you diagnose a case of diabetes, an intensive lifestyle modification which would lead to reduction in weight, that is what we learned from the direct trial. Then use of GLP-1 receptor agonist which could help in beta cell improvement in beta cell function, and then intensive treatment early in the disease. Then there is another study, short-term intensive insulin therapy in type 2 diabetes, a systematic review and meta-analysis. The meta-analysis of trial with short-term intensive insulin trial included in these study. In this meta-analysis, there were 7 trials with different sample size, with different intensive treatment arm. And what message did we get out of this? The message that we get is early intensive insulin therapy with type 2 diabetes leads to remission. Short-term intensive insulin therapy improved beta cell function, insulin resistance, and helps to achieve long-term drug-free glycemic remission. Now, intensive insulin therapy resulted in improvement in HOMA-B, that is beta cell function. Intensive insulin therapy showed a decrease in insulin resistance, and short-term insulin therapy improved beta cell function, insulin resistance, and helps to achieve long-term drug-free glycemic remission. Now, let us talk about what are the predictors. So, which are the patient group in which we can expect diabetes remission over 48 weeks following a short term of intensive insulin therapy in type 2 diabetes. So, these are 25 patients, newly diagnosed patients. They were randomized, double-blind patients with type 2 diabetes, early type 2 diabetes, duration of diabetes less than 7 years. OGTT was done every 12 weeks for serial assessment of insulin sensitivity, alpha response, and beta cell function. And diabetes remission was defined as HbA1c less than 6.5 on no medication for type 2 diabetes. Insulin therapy with bolus, aspart, and basal detamine was given for 2 to 4 weeks, and then placebo therapy was done. What it was seen that duration of diabetes was important determinant of drug-free diabetes remission. So if duration of diabetes was less than 1 year, drug-free diabetes remission occurred in 77% of the population. If duration of diabetes was less than 2 years, it was 70%. If less than 3 years, it was 58%. And when you divide the group in terms of duration of diabetes less than 2 years and more than 2 years, you can see the impact is 56%. People who had diabetes with duration less than 2 years had 56% higher chance of having drug-free type 2 diabetes remission. So at 48 weeks post-intensive insulin therapy, 56% of the participants remained drug-free, and those having diabetes less than 2 years had higher incidence. So what are the predictors? The predictors were lower baseline HbA1c, better baseline beta cell function, and shorter duration of type 2 diabetes. So what we have understood is that remission of diabetes is possible. When you talk about reversal of diabetes, we need to understand the pathophysiology, and whatever intervention we do, that should address the pathophysiology. And this is an excellent summary given by Singla et al. About the impact of different diabetes reversal strategies on various subtypes of diabetes. So they do have 5 categories of the patient. Patient with severe insulin deficiency, then patient with combined insulin resistance and insulin deficiency, people with severe insulin resistance diabetes, then mild obesity related diabetes, and mild age related diabetes. And each group will try to understand what is the probability of diabetes reversal and what are the strategies which can be taken. So let me tell you, when there is severe insulin deficiency diabetes, the probability of reversibility is least. Although calorie restriction and moderate carbohydrate restriction can be a strategy to induce diabetes reversal, but with severe insulin deficiency, probability is less. When there is combined insulin deficiency with insulin resistance, probability is moderate. Here also calorie restriction and moderate carbohydrate restriction is to be done. Now, if you have diabetes because of severe insulin resistance, or it is because of mild obesity related diabetes, weight reduction, decrease in fat, whatever intervention you do, the probability of reversal is very high. So, severe insulin resistance, there is good probability. Here, the intervention that you have to use is moderate to ketogenic range of carbohydrate restriction, calorie restriction, and intermittent fasting, very low calorie diet. These are the interventions that you have to do, which ultimately would lead to decrease in adiposity, both in liver and pancreas. So the twin cycle that we talked about, which led to hyperglycemia, hyperinsulinemia, and insulin resistance, you are trying to reverse that. And ultimately, there is good probability of diabetes reversal in group. Now, we often see obesity as pandemic, and I would say even in India, more than 40% of the people, as per the Indian standards, are obese. And in these group, diabetes is very common. And if we target to decrease the body weight by more than 10% or say 15% by low calorie diet, carbohydrate restricted diet, very low calorie diets, there is excellent probability of getting diabetes reversal. Age-related diabetes is another group where there is excellent probability. Here, basic standard diet with slight negative energy balance is what you need to do. So, at the end, I would like to summarize today's talk about diabetes reversal. The type 2 diabetes is characterized by chronic glucose toxicity, lipotoxicity resulting in progressive beta cell dysfunction. So if you are able to control this glucotoxicity and lipotoxicity, you may reverse the beta cell dysfunction. Very low calorie diet has emerged as a way to remission of diabetes. Evidence shows that early intensive insulin therapy helps in redifferentiation of beta cell and attain sustained drug-free diabetes remission. And early intensive treatment, whatever method, insulin therapy, lifestyle intervention, low calorie diet, which ultimately leads to good weight loss and good glycemic control in early part of the disease. It may lead to partial remission of diabetes, which has been seen in many studies. Thank you very much for your patient hearing. Back to Saurav for further.
Thank you so much, sir. I think a very, very important discussion, and I welcome our chair on the platform, Dr. Chong. Dr. Chong would like to take this session going forward, but before Dr. Chong and we invite our audience for asking questions, I would request Dr. Monica Vasudev, she's from US, to throw some light on this subject. And I will also share some 4 slides which she has sent me. So Dr. Monica, I would request you to please take the forum.
Thank you, Dr. Chandra, and thank you, Saurabh. What a fantastic presentation, and it is of high interest and high value. I think the message that I get from your presentation, apart from being extremely vetted and full of information, is the fact that there's hope. There's hope, and we have to take the information and say, yes, there's different scenarios of which can lead to weight loss and reversal. But I think everybody should know that this is tailored to the individual. Look at the factors. How old are you? What was the age at which you were diagnosed? What was your BMI at the time of diagnosis? When you're achieving weight loss, are you capable? Are you able to exercise? Do you have any other like comorbid conditions? But I think overall, we have a lot more options available today than we had a long time ago. And I think the one image that stays in my mind is that one graph that you had about lifestyle intervention alone, metformin, and the controls, and showing that lifestyle modification caused the greatest gain. I think that's an image that I walk away with today from your presentation, saying that we have it within ourselves to be able to modify through lifestyle, through exercise, through diet, through whatever habits we have, to lose weight. So thank you very much for your presentation.
Thank you.
Dr. Monica, do you want these slides?
Sure. I just wanted to, I had shared these with Saurabh, and I just wanted to give these because there's a lot of terminology now that comes with the weight loss world. And it's just a good review. It's just a very easy read. This is coming, I should give credit to where this is coming. This is coming from the Noom app. There's a lot of apps that are out there and programs that are aimed to teach you and to give you the kind of the story behind how to lose weight. And this just came as a background information. So I just wanted to share this with the group so that they were familiar with some of these new terms, because this is a rapidly evolving field. And so I think that when we were in med school and when we were in training, that we didn't necessarily go through this. And this is the lingo now in terms of weight loss. So that's all. I just wanted to share this. Thank you.
So these were the 4 slides, and I will stop sharing the slides. So let's open the round for question answers. I'm sure a lot of people have questions over here, and we would like our expert to answer that question. Over to you, Dr. Chong, for a minute.
Before Dr. Chong says, let me comment a little bit about what Dr. Monica has shared. I mean, a role of the gut hormone is really very, very important, and the way we have understood it. I mean, role of CCK, and that's the intervention with GLP-1 receptor agonist, which says you that don't eat too much. And of course, lifestyle intervention. These two things put together has literally been able to bring reversal of diabetes in many of my patients whom I do attend in my clinic. And when you start doing it yourself, you gain a lot of confidence, and you feel that yes, these are the possible things that you can very easily do in your day-to-day clinics. Thank you.
Dr.
Thank you,
Chong.
Dr. Chandra. Thank you, Dr. Chandra, for your wonderful presentation. This is a very important topic, I think, globally. This challenge of chronic diseases, visceral fat, diabetes, weight problems. This is a perennial problem that is really taking a toll on all of us and our health systems. Just want to ask what your own ideas about the role of glucose uptake transporters and visceral fat on the reversal of diabetes.
See, there are a couple of things that I want to say about visceral fat. I did try to explain that through twin cycle hypothesis. I did try to say that visceral fat is responsible for insulin resistance that leads to hyperinsulinemia. Ultimately, hyperinsulinemia leads to beta cell exhaustion, and this is how downhill progression of diabetes do occur. So when you decrease the visceral fat, adipose tissue, the lipotoxicity that is occurring in the liver, in the pancreas, which ultimately leads to insulin resistance in liver and beta cell exhaustion in pancreas. If you try to reduce adiposity there, the glucose, uninhibited glucose production that was occurring in liver decreases, and the beta cell exhaustion which was occurring in pancreas decreases. So you do have a better beta cell function, number one. And number two, you have got less gluconeogenesis in liver, which ultimately leads to remission of diabetes. So this is what adiposity role has. Now talking about GLUT receptors, when you do have insulin resistance, those GLUT receptors are not responding appropriately or adequately to insulin. So when you do have insulin sensitivity improved, these GLUT receptors respond better to insulin, and thus the inward movement of glucose into the muscles becomes more effective. And when you do workout, you do exercise, the hunger of the muscle increases and the insulin sensitivity of GLUT receptor increases. So when we talk about interventions, One part was, yes, decrease in adiposity. Another part is lifestyle intervention. I didn't tell about the extensive lifestyle intervention that was done in that study. 150 minutes of at least moderate intensity exercise per week was what it was done in that group. That ultimately led to improved insulin sensitivity in the muscles. The hunger of the muscle cell because of the consumption increased, that led to improved insulin sensitivity in GLUT receptors. So these things put together leads to improved insulin sensitivity and leading to improved glucose metabolism, and that ultimately helps in reversal of diabetes.
Yes. I remember reading some data that muscles are about half of your body's weight. So the muscle mass is critical to help absorb all the glucose load that we eat. And so I always tell my patients to always walk after food, after a meal, get the muscles going and to soak
That is
up
the
the glucose.
that is the best way to control postprandial glucose. You walk for 15 minutes after your each meal, and you can see at least 50 milligram decrease in your postprandial glucose level. I appreciate. I have also seen this in my patients also, even in my clinical practice.
Yeah. And one of the challenges we find is that as one ages, right, one tends to lose muscle mass, and it's quite difficult to keep the muscle mass up. Can I ask what are your thoughts on fructose, versus, let's say, glucose? Because I read that there's some issues with fructose and GLUT receptors and so on. There's some issues there as well.
Let me honestly say, I don't have idea about this. I have not read about it, so I won't be able to answer this question. Anyone else can please take up the question on my behalf.
Thank you.
Or you may answer yourself.
Thank you.
Dr. Chong,
I don't know. I'm
Dr.
honest.
Chong,
I don't know.
Dr. Chong, can I comment?
Yes, please. Please. Dr. Bukhari.
Thank you very much. Thank you very much, Dr. Chandra. I am from Pakistan, Professor Bukhari, and I have seen your Lucknow and New Millennium, a beautiful city.
Thank you,
And
sir.
it was a really beautiful lecture. And the better word, reversal, is the better word we should use. The remission you use, I think. Thank you very much. What I want to add a few things is that is the intermittent fasting. The intermittent fasting not only at around about 14 hours, it not only reduces the fat, it also increases the sensitivity of the glucose. You also know better than me that in most of the type 2 diabetes, there are 7 to 8 pathogenesis which are affecting in the type 2 diabetes. And it is very important for the consultant to understand which pathogenicity is behind the type 2 diabetes. So it is much better to monitor the level of insulin until and unless there is the dysfunction of the beta cells. So the important things in reducing that we have seen in Pakistan, and you know that about 33 million people in Pakistan are suffering from diabetes. Almost and more than 500 people all over the world are suffering from the diabetes. So this is the new concept. I think if you use this concept with your patient, changing the lifestyle, reducing the weight, and adopting your diet style with intermittent fasting can get the remissions of the diabetes type 2, not diabetes type 1. Thank you so much.
Thank you, Dr. Bukhari. Anyone else?
No, Dr. Chandra, can you comment on my
fructose.
topic? Dr. Chandra,
sir, I agree. I absolutely agree.
Thank you
to
so
this.
much, sir.
I absolutely agree to
Thank
this.
you so much, sir. Thank you so much, sir.
Intermittent fasting. The concept of intermittent fasting is that you try to decrease
Yes.
the total amount of
Yes,
calories.
yes.
So when you are eating for only 8 hours in a day,
yes,
you tend to reduce the calorie intake by about 30 to 40%. And
excellent.
what you target is that your total calorie intake should be less than 1000 calories. When you talk about very low calorie diet,
Yes.
often the target is to bring the calorie intake to less than 800. And the mechanism that it has, a low level of ketogenesis occurs. When you
Hmm.
continuously keep low calorie diet, the fat deposits starts getting dissolved or getting absorbed, which ultimately leads to a low level of ketosis. And this
Yes.
low level of ketosis suppresses your appetite. So 3 to 4 days down the line, when you are doing intermittent fasting or low calorie diet, your hunger starts decreasing, which ultimately leads to continuation of the intermittent fasting or low calorie diet. And when you do have low calorie diet with calorie deficit, of course, there is decrease in fat content, which ultimately leads to remission of diabetes, which we have been discussing right now. Thank
Yes,
you.
thank you, sir. One thing I want to add more, that if in intermittent remissions, your last 1 hour, you are sleeping, your gut hormones, as discussed by the Monica, will act more actively, and that will help more in getting the remission of the type 2 diabetes. But one important thing is that, as you tell, that the duration of the diabetes is very, very important. This remission is only possible until and unless your beta cell are functioning and there is no dysfunction. But with the longer time, when they get dysfunction, then the remission is, I think, impossible. Thank you, sir.
Your questions, if you have questions, please write on the chat box who are not from CMAAO. So one of the questions which is what is type 2 false positive error, which people say, and the role of HbA1c we are talking about, and the role of sleep. Can a unmonitored sleep cause diabetes?
Okay, so this is very, I mean, the second part, that role of sleep and its importance in diabetes is very, very important. The concept of chronomedicine or chronology, the way you sleep, the way you get up, and the sleep cycle is becoming very, very important these days. Now, why it is becoming important? Because diurnal variation do occur in different hormone, and melatonin secretion usually increases during the sleep time, which has got its impact on different pathophysiology. When there is dyssynchrony in between day, diurnal variation, day and sleep variation, this synchrony, which leads to the appropriate pathophysiology, goes away. Now, what happens that when you tend to sleep late, this synchrony within the neurohormones gets deranged, that ultimately leads to increase in counter-regulatory hormones, ultimately leading to diabetes. This is one pathophysiology which is said about sleep cycle, and that's why we see that those who sleep late, get up late, have got higher incidence of obesity, higher incidence of hypertension, and higher incidence of diabetes. Now, there is another concept other than neurohormonal axis. When you tend to sleep late, you tend to take snacks very frequently. Late night snacking is very much common. So ultimately, you tend to eat more calories, and that ultimately leads to diabetes. When you get up late, probably you are missing most of the activities that people do in the morning, maybe regular exercise or the amount of calorie burn or walking, whatever you do. So these are the two concepts which suggest that if you have abrupt sleep cycle, delayed sleep, delayed getting, that, or I mean, say, night owls are, predisposed to diabetes more than early birds. So these are the two concepts which says how this sleep cycle is associated with diabetes.
Thank you, Dr. Chandra. I totally agree with you. I think we see this quite a lot in clinical practice.
Thank you, sir.
If there are any other questions for Dr. Chandra, if not, we will call it to a close. It's 1 p.m. already, and we thank Dr. Chandra for his wonderful presentation, as most illuminating, most interesting, and very appropriate for our challenges currently in all our healthcare systems. So thank you very much, Dr. Chandra, and very fascinating topic. That this is always fascinating topics for all of us, and we look forward to having you again for another presentation.
Thank you, sir.
Before we session, we just need a take-home message if you can give. I know changing of lifestyle and walking is very important for controlling the diabetes. And if you cannot control the diabetes, at least if you cannot reverse the diabetes, at least whatever your efforts are, you can control the diabetes, and that is also very good for your lifestyle. So please give your take-home message before we can end the session.
Thank you very much, everyone. What I would say is that the evidence that we do have, remission of diabetes seems to be a possible option in appropriate population. So if duration of diabetes is, say, less than 5 years or 6 years, if a person is obese or obesity related diabetes is there is insulin resistance, and in them, if you do appropriate lifestyle modification with early intensive treatment of diabetes, you tend to reverse the beta cell dysfunction. You tend to reverse the pathophysiology associated with diabetes. So if you choose appropriate population with appropriate intervention, remission of diabetes is possible, and even reversal can be achieved if prolonged remission is seen in these cases. Thank you very much.
So thank you so much. With this note, we will look to end this session, and it was a very good session. I thank you for Dr. Chandra for giving us immense knowledge about diabetes reversal. I think it's a need of our, and we would welcome him for another session in few weeks with more questions coming in from Facebook and everywhere else. Thank you so much, Dr. Chandra, and thank you everyone for joining in.
Thank you. Thank you.